Good evening. It's so nice to see a nice crowd of you out there. Tonight you're going to, get to hear about the heart in maybe a little different way than we've talked about before. There are differences between men and women, which we've all understand. That also includes the heart. So to begin our topic tonight, I'd like to introduce Dr. Panteha Rezaeian. She received her medical degree from Tehran Faculty of Medicine in 2001. Then she practiced medicine in the General Hospital, private clinic setting, and refugee camps while she was serving as executive director of the largest national registry project. Dr. Rezaeian was accepted in general surgery residency, but she instead decided to abort the leading cause of death worldwide, cardiovascular disease, by pursuing her passion, preventive cardiology. Dr. Rezaeian discovered that family medicine is a unique specialty which equips her with profound understanding of cardiovascular diseases progression stages from childhood to elderly ages. After locating to the United States to join her family, Dr. Rezaeian completed the family medicine residency program at Loma Linda University. She is a board-certified family physician, but moreover, Dr. Rezaeian has accomplished 2 fellowships in the field of preventive cardiology. She has done the fellowship for cardiovascular CT angiography at UCLA Harbor Medical Center, as well as the Women's Heart Disease and Health Fellowship at Cedars-Sinai Heart Institute in Los Angeles. Dr. Rezaeian is the only primary care physician nationwide to have both of these fellowship trainings in preventive cardiology. Dr. Rezaeian enjoys caring for patients from adolescence through all stages of adulthood. She has an interest in preventive cardiology and women's cardiovascular health. She is passionate about delivering comprehensive care with a wholeness approach and treating her patients as a whole person. Dr. Rezaeian actively participates in cardiovascular research and has presented and published numerous articles about cardiovascular disease. She received several awards for excellent patient care and patient satisfaction, regardless of patient communities that she has served, refugee camps, or celebrity communities in Beverly Hills. Please welcome Dr. Rezaeian.
Good evening, everybody. Can you hear me well? Yes. Okay. So I'm so glad to be here to discuss about one of the most important healthcare problems in last century. So before I start, I'm going to ask 2 small little pre-tests. Probably you receive it in your package, but I will ask you, and then please raise your hand if you think that the statement is true. Okay. So first pre-test. The heart disease is the number 1 killer of the men, and breast cancer is the number 1 killer in the women. Please raise your hand if you think that's a true statement. Okay. And the second statement is about the age and heart disease. Heart disease is the disease of the elderly population which does not impact younger adults. True or false? Okay. I'm glad that you know the answer. Okay. So, but then probably it was all the package had my second slide, so you know the answer. So, okay. So, I am here to talk about the facts about the cardiovascular disease in the women. Actually, cardiovascular disease, as you mentioned, is the number 1 killer of the women worldwide, affecting women of all ages. So, this is the cardiovascular disease is taking more life per year than all type of the cancer combined. So we are not talking only about the breast cancer, all cancer combined. 1 out of to you women here will be impacted by cardiovascular disease in your lifetime. And 1 out of the 3 person, just men or women, can be would be die because of the cancer, because of the heart disease. So actually, despite the increased awareness over the past decades, only 54% of the women recognize that the heart disease is their number 1 killer. So it still means that we need to work hard to spread the awareness in the community. So every minute, somebody's mother, sister, wife, daughter will be die because of the cardiovascular disease, stroke, heart attack, or any type of the cardiovascular related issue. Just imagine every single minute, 1 person will be die because of that. So one woman, and it's only about the United States. So comparing the cardiovascular disease death versus the breast cancer death, there is a study they done in 2000, actually a long time ago. Even at that time, that the breast cancer was not getting that much of the improvement as far as just helping the people, and not getting that much of the people dying because of the breast cancer. They showed that in all different ages, cardiovascular disease can kill more women compared to the breast cancer. So then is probably you were saying, okay, why we are then thinking that the breast cancer just came to our mind? We all can think about somebody's, usually young women, dying because of the breast cancer. Just because cardiovascular disease killed people. It kills people, and most of the time, more than half of the time, the first presentation of the heart attack could be sudden cardiac arrest and sudden death. Just imagine, they do not have a time to say goodbye to their family. They do not have a time to going to the chemo, and it does not stick to our mind that because they happen so suddenly. So, for that specific reason, probably we need to just do more work on the cardiovascular disease, because right now, because all the improvement on the treatment of the breast cancer, the mortality rate or death rate of the breast cancer going down to the 4%. But we have a long way for cardiovascular disease to get that decrease in the number. Okay, so since 1984, more women die from the heart attack in the United States than men. So even though we have been taught in medical school, especially at that time that I was in the medical school long time ago, so in 1990s, and just imagine just all the decades before, we have been taught in medical school that the cardiovascular disease is the men disease. And they did a statistic in 1984, and as you can see here, the blue line is the death rate in the men because of the cardiovascular disease, and the red line is the death rate of the cardiovascular disease in women. And actually, as you can see here, the cardiovascular disease is a women disease, right? You can see that the number of the death is going up since 1984, but the men mortality going all the way down. So, and then at that time, the medical society was thinking, okay, wait a minute, what's going on here? Why all of our diagnostic and therapeutic strategy coming from all the research that has been done in the medical field in cardiovascular disease does work very well in the men, but it doesn't help the women at all. And actually, the number is going up no matter what we are doing and no matter what we are advancing in the diagnostic and therapeutic in the cardiovascular disease. So then they just, they suggested that could be the research that we have been done and then just, result in all those diagnostic and treatment in the cardiovascular disease has been done mostly in men. Actually, 25% of the research subject has been women. Just imagine, they did a study in mostly men. All those presentation, all those information which ended up with the effective treatment coming from the male population. And then that's the reason that does not work in the women. So in 1983, Barbara Streisand played a movie. I don't know if any of you remember Barbara Streisand, that movie, Yentl. She played a movie, and actually she was demonstrated as one of the 19th century's young lady who wanted the education and studied Talmud. But how she was able to get the education? She needs to impersonate like a man. She needs to look like a man. She had to make other people believe that she's looked like a man to be able to get the same right as a man had. So Dr. Bernardine Healy, she was a cardiologist. A couple years after, she wrote an editorial to the New England Journal of Medicine, and she said the women dying more from the cardiovascular disease because of the Yentl syndrome. So what does it mean? Because they're not getting diagnosed because the cardiovascular disease in women is not look like a cardiovascular disease in men. Okay? So, and then a few years after, I believe in 1991 or 96, she became a first women chair of the National Health Institute, which is the number one department of just spending or just allocating the grants and research budget. And she started fighting for the women. So I said, we need to dedicate more money in the research of the related to the women. And after just lots of challenges and they were questioning her. No, it's too expensive, and we are not doing that. Finally, she said, no, women voted. We need to do that. And finally, they start a huge, very important study. They call it Women Health Initiative, which is the most of us has been. Get benefit from this study. They did a study in osteoporosis in women, colorectal cancer in women, breast cancer in women, and a small part of that money went to a part of the NIH which was related to the lung and heart department, and a small part of that money then went to the women cardiovascular disease. They started women ischemia syndrome evaluation, which was one of the studies looking why the women has more heart attack, and just all of those heart problem. So if I'm asking you what would be the presentation of what the heart attack look like, what came to our mind is coming from the movie that we are seeing, or what we heard, or just our family member had it. Usually there is they call it Hollywood heart attack, because usually in the movie you can see, a man, usually elder ages, a little bit overweight, and just having put the hand on the chest and just crushing chest pain, bending over, falling on the scene, and then just gasping for air, and the pain is in the center of the left side of the chest. This is the male pattern. It doesn't mean that women does not have the same or similar symptoms. Some women have similar, but not all the women. The majority of women can have the vague symptom, as I will mention to you what would be. So, what would be the heart attack symptoms in women? Chest discomfort. So, I have been seeing so many women coming, and the only symptoms they had, it was very mild or moderate chest discomfort, saying, I don't know, I'm feeling something wrong in my chest. Maybe it's a little bit tightness. They're usually saying the tightness. And sometimes they're saying, okay, I feel my brow is so tight. For some reason, I don't know, I didn't gain weight. For today morning, I start feeling that something is wrong in my chest. It's a little bit pressure. I took off my dress, still I'm feeling the pressure. And sometimes the pain is going to the back. Sometimes they're saying, okay, I have a pain in my back. And sometimes they're thinking, oh, just some week, I'm not feeling okay. So something very, very non-specific. The second symptom that actually is very, very common is feeling fatigue, feeling tired more than the norm. They may feel very overwhelming fatigue and tiredness, and they cannot do anything. I had one of my patients think, doctor, I'm just doing all of my work at home by myself. Today morning, I cannot come out from the bed. I do not have any other symptoms. I do not have any runny nose or any other things. I'm so fatigued. And another symptom could be just shortness of breath. They're thinking, okay, I cannot take a full deep breath. I think that I ran a marathon, but I didn't do basically any move, but I cannot take a full deep breath. Sometimes patient coming and saying, okay, especially women saying, I have a pain between my shoulder blade. Most of the time, especially in emergency department, are thinking maybe that's the pain from the gallbladder, especially if the patient fit with the other symptoms of the gallbladder, which, as you can see later on, those symptoms also could be the symptoms of the heart attack in women. I had a patient, she was actually complaining of the lower jaw pain for 2 years. She went to so many doctors. She was asking maybe something is wrong with my tooth. They fill out all the cavities. They were thinking maybe they need to do some root canals. She finally went to the ENT. She was thinking maybe I have a TMJ, maybe something is wrong with my ear. But guess what? Patient had a heart attack. I mean, they call it a stable angina. She didn't have a heart attack at that time, but then after 2 years, when she came to our clinic, we finally found out that, she has a heart issue. Also could be the sleep difficulty. Patient cannot have a good sleep at night because of usually the pain and discomfort on the chest. And sometimes people saying that I have a gas or just acid reflux, indigestion, could be as vague as some acid reflux or indigestion. Sometimes it's associated with the nausea and vomiting, sometimes not. Sometimes cold sweat. And something important about cold sweat, just imagine during the premenopause and menopause, the patient may have that sweating, and in the women, actually, this sweating of the heart attack and cardiovascular disease could be associated with the flushing on the face, which actually the same thing that we have in the hot flashes from the menopause. So you can see the symptoms are very confusing, very vague. And then anxiety. Sometimes people have the anxiety without any significant reason. I remember when I was in the medical school, a woman going to the emergency department and having a chest discomfort and anxiety, which now you can see both could be a sign of the heart attack, and saying, you are not a man, you do not fit the male, they didn't say male pattern, but right now we know that they were looking at the male pattern of the cardiovascular disease and heart attack. So many patients has been released from the emergency department saying that you do not have the heart attack. And especially at that time, there was not a troponin test. And of course, we didn't get that much of a diagnosis of the women cardiovascular disease. I mentioned about nausea. Could patient had the nausea with or without vomiting? So, do you remember I mentioned about the NIH, National Health Institute, allocate a specific amount of money for the research in the women, and they start the women ischemia syndrome evaluation. And actually, Dr. Barry Mears at Cedars-Sinai, she was the chair of that study. They did a study in the men and women, and you can see the cross-section of the coronary artery disease, which is the main supply of the blood to the heart. In the top picture, you can see how does it look like the fatty plaque in the women coronary artery disease. You can see it's just nice and smoothly going gradually all the way in the vessels. But look at the men coronary artery disease. It's just big clot and just, is very, very prominent. You can see the big clot. And then a patient going to emergency department, usually men, severe chest pain, very typical, they call it typical chest pain, and just, feeling that elephant sitting on my chest or severe stabbing chest pain. They are doing the EKG. Usually the picture of the EKG changes in the man is more significant for the heart attack. And they're taking the patient in the cath lab. Just imagine, that big clot can easily be seen in the cath lab because they're just injecting the dye inside the coronary artery disease. Are going from growing all the way, sending a wire and going to the heart, coronary artery disease. They inject the dye, and what they can see, a big clot blocking the way. So they call it obstructive coronary artery disease. So easy to be seen in the, they're just putting a lot of x-ray, and then they can see that a shadow of the dye not going through the coronary artery disease. So easy to be diagnosed. They just put the stent or fix the problem, and patient can get treated. But the women going to emergency department, first of all, the symptom is not really typical. They call it atypical the most of the time. Not all the time, but the most of the time. The EKG changes usually is not as significant and prominent as the men cardiovascular, men heart attack. And when going to the cath lab and injecting dye, you can see it's not a big clot, just closing or blocking the way of coronary circulation. And of course, we cannot see anything, and it's not anybody's fault. It's just the angiogram is not the best way to find this type of the coronary artery disease. So they did another study. In Vice, and they actually they use more technology for seeing what's going on. And at that time, the chair of the Vice study, Dr. Barry Mears, was thinking, okay, so wait a minute. There is a general observation that usually if the people just getting obese, how the men getting obese? Usually just focal obesity in the abdomen, just, beer belly. How the women getting obese? All over, in the hand, in the abdomen, and just, in the legs. So they were thinking maybe that similar thing happened. And the previous study basically given an idea, maybe that's the correct statement. So they did a study. They used intravenous ultrasound, IVUS, to see what's going on inside the coronaries. And guess what? You can see the upper picture is the study done in the men. And as you can see, is just, lumpy bumpy. And that red part is the basically contrast or dye they are doing in the angiogram easily can be seen in the angiogram, right? It's very obvious. The women coronary angiogram is not that obvious to be diagnosed. It's just very smoothly narrowing and is really easy to be missed. So after just putting all of those effort and trying to figure out what's going on in the women cardiovascular disease and just all the research that they have been done, they noticed that the statistics shows the women cardiovascular are getting actually declining, and same thing happened in the men as well. And one thing that before I forget to tell you, that even though I'm talking about the female pattern of cardiovascular disease versus male pattern, it does not mean that men cannot have a female pattern of cardiovascular disease, or also the women cannot have the male. So still just a small part of, some portion of the men can have a female pattern of cardiovascular disease, vice versa. So it's not 100%, it's not just definite line between men and women, and they can have the different type of the men or women can have the male or female pattern of cardiovascular disease. So as you can see, the death rate decreased significantly in 10 years. 1997 that they started putting the more research found until 2017. And the most recent slide I have as far as the statistic is in 2013. Now basically that gap's already closed. Now we have almost similar number of the men and women cardiovascular disease death rate. And you can see the first time they noticed in 1984, it was a new female majority. In 1991, 92, they started Yantel, and just Dr. Healy talking about the Yantel syndrome. And finally, they had decreased the mortality rate significantly, both in men and women. However, that drastic change is mostly in women because now they have more study done in the women and have the better idea of what's the difference of the men and women cardiovascular disease and have the better diagnosis and treatment. Do you think that we are in the ideal shape? Still, we need more work to do. Still, there is, actually, I was checking the CDC last night, and some more research has been done on the mortality. Now there is a concern about the number of cardiovascular deaths in the young women not declining as the other ages. So that's the big concern and would be a big wake-up call for all of us. As far as the patient, be a little bit more mindful of the symptoms and just going and getting some more medical attention. And as far as the physician, to do more work on the research and diagnose the cardiovascular disease in women, as we need to just work more in that area. And that's actually very concerning. The women under less than 55 years old, still we do not have that much declining of the cardiovascular death rate. So women remain the majority of victims and still receive fewer intervention to prevent and treat heart issue. So why? still, as I mentioned, still 54% of the women does not know the cardiovascular disease is their main killer. Still, they don't know about the difference of the symptoms, and of course, it's not getting the medical attention. Less cholesterol screening, fewer lipid-lowering therapy or statin, and this part is I'm really blaming the media, because all those advertisements against the statin, I don't want to say it's not true, but they are exaggerating the side effect of the statin. And actually, I would love to bring a slide. They did a study in Canada, and they just put two different groups. One group was getting only the sugar pills, the other group getting the statin. Both groups, they didn't know they are getting the sugar pill or they are getting the actual medication. The doctor was treating those patients, they didn't know. Basically, they call it double blind, which is just, put the accuracy of the results higher than other type of the research. And after doing a big trial, they noticed that the most of the people complaining of the muscle ache or joint problem is not because of the statin. Actually, they had the very high rate also in the group that they were taking the sugar pill. So they call it nocebo effect. It means that because we are remember, they used to say placebo effect. You are taking a sugar pill, you are thinking you are taking some treatment, you feel improvement. They call it placebo effect. Now they call something nocebo effect. We are hearing about side effect of the medication. And then we are taking medication. So I'm getting the side effect. I'm hearing all the time. So they call it nocebo effect. So unfortunately, so many people has been prescribed statin, which is, I will tell you later on, that it's one of the medication decreasing the cardiovascular death. But at least I have lots of patients. I'm sure that Dr. Banka also has patients saying, doctor, I'm afraid I'm getting the side effect. And they are not starting. Guess what? What's happened? They will get the side effect of cardiovascular disease, which is death. So, I'm sorry, but it's one of the sad part about fake medical news. I think we need to do something about that. Okay, and less use of the heparin, less use of the aspirin during the myocardial infarction or heart attack, less antiplatelet therapy, and secondary prevention, fewer referral to the cardiac rehab, and less implant of the defibrillator. I will just give you a very, very small little information about the microvascular angina. As you saw in the past slide, I was saying that the fatty plaque deposition in the men and women is different in the coronary artery disease, but also they noticed in Weiss study that the women also has more something they call it microvascular disease. So it has more disease in the smaller coronary artery, a smaller branch of the main coronary artery disease. Could be a spasm within the wall of these very small arterial blood vessels, cause reduced blood flow to the heart muscle and leading to a type of the chest pain, which actually showing that those people, they have most of the vague symptoms: chest pain more than 10 to 30 minutes, shortness of breath, a sleep problem, fatigue, and lack of energy. So you could see all those atypical symptoms of the cardiovascular disease in women is just meet the criteria of the microvascular angina. You can see in this picture, those bigger pipe is the main coronary artery disease, and that small little vessels is the small little branches can be affected in the women cardiovascular disease. Broken heart syndrome. Probably you have been heard for a long time. They were saying, okay, patient just have a very sad news, some stressful event, some loved one died, or just very major physical distress like a just major surgery, major disease happened, and for a long time they didn't know what's that, and then finally a scientist, I believe it was a cardiologist in Japan, they diagnosed something they call it Takotsubo cardiomyopathy, and the symptoms could be very similar to heart attack, but usually is a temporary, but still they will do the echo, and then you can see that picture ballooning of the lower chamber of the heart. Okay, so I'm going to speak about the prevention very quick. First of all, it was a big discussion about the prevention of the heart disease by doing the hormone replacement therapy and HRT. So now is a subject of debate. They were saying that it can increase the heart attack or thromboembolism or making the clot in the coronary arteries because of the estrogen. After that, they changed and said no, it's not. And then the most recent study I actually was reading a few months ago, it was saying if they are starting first couple years of the menopause, probably it does not increase the heart problem, but if they are starting or continuing for 10 years, maybe they can cause some problem. But for this one, still we need to do more study to get to the final answer. Quit smoking is very important. So lifestyle change is a main part of the cardiovascular prevention. Physical activity is the other one. Improving the diet is very important, and quit smoking. As far as you start quit smoking, after 1 year, the probability of the coronary artery disease decreased 50% compared to the time that the people were smoking. So, and then just walking 30 minutes a day can lower the risk of the heart attack and a stroke. The American Heart Association and American College of Cardiology both really encouraging Mediterranean diet. And I will mention about Mediterranean diet in next slide. So just I will leave it for the next slide. It's important to schedule an appointment with your physician. If you have a symptoms, one of those symptoms I mentioned, please don't think that, okay, you need to take care of your family. Lots of women does not getting the medical attention because they put their families, loved one, husband, children, the more priority than themselves. Just remember, as we are going to the flight, they are saying, first thing that they're saying, okay, if there is something happen in the flight and in the plane, first put the oxygen for yourself and then help your children. I remember first time I heard that, it doesn't make sense. My children is more important than me. But then I thought, okay, if something happened to me, I cannot help my children, right? It makes sense that put more priority to yourself to be able to help to your loved one. Make sure your physician is aware of difference of the cardiovascular disease between men and women. This slide is very important. Very interestingly, 1 month before the heart attack, people can have some symptoms, and then usually women can have unusual fatigue. 75% of the people had unusual fatigue, sleep disturbance, shortness of breath, indigestion, and anxiety and heart racing. So if you continue having those symptoms, please go and see your doctor. About the Mediterranean diet, I mentioned that it's important to start the Mediterranean diet. I'm always telling my patient, don't think going to the Mediterranean cuisine and eating all those food over there, it means that you have the Mediterranean diet. Mediterranean diet has a specific definition. Mainly, at least half of your meals needs to be the vegetables and fruits, mainly vegetables. A small part going to the poultry, especially, before putting the poultry, we need to have more fish, less than fish, poultry, and then less than poultry, we can have a few meals of the red meat. Physical activity is very important. If you are able to do at least 30 minutes of exercise at least 5 times a day, moderate intensity exercise, that would be perfect. If for any reason you have a knee problem or any other problem you cannot do it, at least 10,000 steps a day. Include all those walking that you are doing for your daily life. Walking, cycling, dancing, swimming, all could be anything that works for you. Please do that. And know your ABCs. A, antiplatelet and anticoagulant, something like aspirin. Those things that I put my mark in the yellow, it decrease the mortality significantly, at least 90% reduction in the recurrence of the major adverse cardiac events. Angiotensin converting inhibitors, all of those, lisinopril, enalapril, all of those, bilazopril, those pill, or the family member, which is the ARBs, angiotensin receptor blockers, like losartan, valsartan, candesartan, all of those also could be decreasing the mortality. Control your blood pressure, especially beta blockers, something like a metoprolol or Coreg. Those also decreasing the risk of the major cardiac events. And cholesterol management. One more time, statin shows decreasing the death of the cardiovascular disease. Please just think about that. It's important to listen to your doctor. If your doctor advising you to do that, it's better to take it seriously. It's important. It saves lives. All of those yellow color I put over there, those medications save lives. Please take it if your doctor advised about that. And almost to my last few slides. So technically, if you have the obstructive coronary artery disease, male pattern is easy to be diagnosed. If the people have the microvascular or non-obstructive coronary artery disease, like what the you can see, just female pattern, still have the more mortality rate. And the post-test, I'm sure that you all know the answer. Actually, you answer all those pre-tests right. The heart disease is the #1 killer of the women, all ages. And the last but not the least, I owe the depth of gratitude to my mentors, Professor Matthew Budoff. He is the endowed chair of the preventive cardiology. He is a nationally and internationally renowned physician in cardiovascular and cardiovascular CT angio and preventive cardiology. I had a chance to learn from him in my fellowship, my first fellowship, and the second, Professor Noel Berry Mears. She is incredible visionary woman and physician. I learned the most of what I talk about this night from her. And she is the director of the Barbara Streisand Women Heart Center. She is the director of Preventive Cardiac Center at Cedars-Sinai, and she is the director of the Linda Pauline Women Heart Health Program and Erika Glazer Women Heart Program, and professor of medicine at Cedars-Sinai Medical Center. And the last slide. Please be your own heart hero. not because you are coming here and tonight and just, I want to make it important, because you owe that to yourself, to your family, and to your community. Please take it seriously. It's a very important subject. Thank you for your attention.
All right, so now we can hear about the man. Dr. Gaurav Banka completed his bachelor's degree at Harvard University, medical degree at Stanford University, and residency and fellowship in cardiology at UCLA Medical Center. His clinical interests are in prevention and imaging. He is board certified in internal medicine, cardiology, echoes, nuclear medicine, cardiac CT, and MRI. He is the director of cardiac imaging at Core Cardiology and the Echo Lab at Torrance Memorial. He is also part of the Department of Radiology and involved with cardiac CT and MRI. He has also served on the National Guideline Committee for Cardiac Rehab, published multiple peer-reviewed research articles, and worked on healthcare at the World Health Organization and Clinton Foundation. Please welcome Dr. Banka.
Thank you, guys. So now that we have you worried that you're going to have a heart attack tomorrow, let's talk about what do we do to figure out what your risk is and how to move forward. So we're going to focus on today two big categories. So one, if you're asymptomatic, what do you do? Okay, and then the second half of the talk, we're going to focus on symptomatic patients. Okay, so the vast majority of, so as Dr. Rezaeian mentioned, heart disease is a major killer. I'm not going to go over the stats again. So again, focusing on asymptomatic patients is kind of where we're going to get the biggest bang for our buck. Once you've already had heart disease, it's already too late, and we've kind of missed the boat at that point. So, most people, when they go see their doctors, they usually get an EKG every year, they get some blood tests, everything looks normal, and so they're told you have nothing to worry about. And that's usually a good first step, but it's kind of like a bird's eye view of looking at a house. You get a rough idea of what's going on, but you have no idea what's going on in the plumbing, you have no idea what's going on with the electrical system. It doesn't give you enough information. One of the interesting things is over 50% of patients who present to the hospital with a heart attack or heart disease have completely normal cholesterol. And that's shocking, because I see patients every day say, oh, I have normal cholesterol, I'm not at risk for heart disease. Not true. The other interesting thing is when we've looked at patients who are completely healthy, no diabetes, no cholesterol, no smoking, normal blood pressure, over 50% of those people have some sort of plaque build up in their arteries. Okay, so they have heart disease even though they don't know it. So what we have to do is find those people who are the highest risk, okay? Not everyone is high risk for heart disease. We have to find those people that are the highest risk and really focus on those people. So, I always say a picture is worth 1,000 words. So here's a picture of someone who had what's called a coronary calcium score. It's a CT scan, and we're looking at the plaque buildup in the arteries of the heart. So you see all this white stuff here. That's all calcified plaque. Now, Dr. Rezaeian and I see patients every day, don't want to take a statin, they don't want to exercise, they don't want to lose weight. When I show them this picture, all of them immediately start doing all of those things. And so it really changes things. But it also helps me as a doctor know who to push more aggressively on in terms of those things we talked about. So basically what that calcium score is basically sitting in a CT scan. It takes about less than a minute to get the scan. You come in, you hold your breath for a few seconds, you get some EKG leads attached, and you're on your way. And what that's looking for is looking at the plaque buildup. So taking the analogy of the house again. The EKG labs are looking at the house from up in the sky, gives you a bird's eye view. The coronary calcium score, we're actually looking at the plumbing in the house. We're seeing how much plaque buildup there is. okay? If you have a 60-year-old house, there's going to be some plaque buildup, just like a 60-year-old male or female was going to have some plaque buildup. And this is how we find out how much plaque you have. Basically, the way plaque starts, it starts at an early age. All of us have plaque at an early age, and as it accumulates, eventually calcium builds up over it. And calcium's there to kind of stabilize the fatty plaque, is what we think. But it's a marker of bad things going on in the artery, okay? So there's calcium builds up, and then sometimes there's eruptions, like a volcano, and that's what a heart attack is. So these are here on the last two slices. That's an acute plaque rupture. Sometimes that's a heart attack. The last slide there is blockage. So you can either have a heart attack with chest pain, or you can have slow accumulation of blockages, and that can cause chest pain. So that's called more stable angina. The data on the calcium score is very, very strong. There is a big study called the MESA study where they looked at they followed patients over 10 years. These are over 10,000 patients. And they looked at everything. They looked at their cholesterol, their hypertension, their family history. They looked at their calcium score. They did every single test imaginable. And the calcium score was the best predictor of who was going to have heart disease in the future. So those who had a very high calcium score were 10 times more likely to have heart disease than patients who had no calcium. There was a randomized control trial done at Cedars where they took 1,000 patients who were, done at St. Francis, who were asymptomatic, and they had high calcium. And so they said, okay, let's give half the group statins and half the group sugar pill, okay? What they found is that at the end of about 5 years, there was a significant reduction in heart disease and heart attacks on those patients who had gotten the statin because of their high calcium score. Unfortunately, I'm not going to get into the intricacies of statistics, but it barely missed statistical significance. So no insurance company really pays for this test because of this barely missing significance. When they looked at those patients who had very high calcium, they found that there was a statistical significance, okay? So we know that this is the best predictor of who's going to have heart disease in the future. So the downside to this test, it's a tiny bit of radiation, okay? There's been no evidence that a tiny bit of radiation causes any damage. Just to put it in perspective, women get screening mammograms every couple of years, every 2 years it changes, and that's about a half a unit of radiation. This calcium score is about 1 unit of radiation. And it's a one-time thing that I recommend for my patients to figure out what their risk of heart disease is. Again, as we talked about, the risk of dying from breast cancer is much lower than the risk of dying from heart disease, but we don't do this calcium score. So the other test that can help figure out how much plaque or buildup there is something called a carotid ultrasound. And this is no radiation, it's an ultrasound, and you can sometimes see plaque buildup. It's not as accurate, it's not as good of a predictor of heart disease, but it's something I tend to use in younger patients. And so this is kind of what a carotid ultrasound is, looking at the plaque buildup. So, with that information, what do? We find out those patients who are the highest risk, and then we focus on blood pressure, we focus on cholesterol, diabetes, stop smoking, eating healthy, being physically active, and losing weight. All those things that Dr. Rezaeian talked about already. So my approach is, if I see a patient generally above the age, a male over the age of 50 or female over the age of 60, I'm going to order a calcium score because if they're interested in knowing what their risk of heart disease is, because it's the best predictor. If you have a calcium score of 0, you're very low risk of having heart disease in the future, and that gives patients a lot of comfort. Now, if someone says, they have an early family history of heart disease, they have diabetes, high blood pressure, then I consider doing the calcium score sooner. For younger patients, I can consider doing a carotid ultrasound. So I don't do the calcium score if the patient's already on maximal medical therapy. So they're taking their statin, they're taking their blood pressure medication, they're exercising, they're doing all the right things. Calcium score is not going to change anything for those patients. If there's a high calcium score and the patient's asymptomatic, because this is an asymptomatic test, then I don't do any further testing based on the calcium score. I don't do a stress test. I don't do an angiogram, typically, okay? Patient has known heart disease. I don't do a calcium score. One of the questions I get all the time from patients is, I have a high calcium score. Should I stop eating calcium? No, it doesn't work like that. The calcium is protecting the plaque buildup, okay? So the calcium intake does not affect plaque, okay? The other thing is, some patients want to check what their calcium score is, next month. It doesn't change within a month, okay? You can consider doing it within 3 to 5 years, but typically I don't do that, but you can consider doing it. So again, as I talked about, unfortunately, insurance companies don't cover this test, and it's a real tragedy. Don't have time to go in detail about it, but it's based on that statistical significance being barely not met. But we've got the price down here at Torrance Memorial. It used to be much higher. Convinced them to bring it down to $200. So it's the lowest price here in LA, $200 for this calcium score. And the cost of a heart attack is over $4,000. So when I talk to patients, none of them usually have any problem paying for this test. There's a good movie that I recommend to everyone when I talk to them about this test. It's called The Widowmaker. And it talks about how we do a lot of unnecessary things in cardiology. We put stents in people who don't need them. We do unnecessary things. This is a preventive test that can save lives. But insurance companies don't cover it, doctors don't order it. And this movie talks about the pros and cons and goes into depth about it. In Texas, they actually got something right there, and they passed laws that mandate insurance companies to cover for it. So you can watch it on, I think there's a version of it on YouTube. You can rent it on iTunes or Amazon Prime. Okay, so that's for so we talked about asymptomatic patients. Now these are patients, now we're gonna focus on patients with symptoms. What do we do for those patients? So again, the slide is slightly out of order here. I wanted to stick with the artery blockages first. So when symptoms that make me concerned about either blockages in the artery or problems with the valves are shortness of breath, chest pain, chest pressure, discomfort, throat, jaw, arm pain, all those things that Dr. Rezaeian talked about, kind of simplified it here, okay? Things that are more concerning is if you are having that with exertion, because that's when the heart is stressed. Or if you're having those symptoms while laying down, because fluid may be accumulating in your lungs. So it's maybe a sign of heart failure. So one of the first things we do for patients who have those heart symptoms is something called the transthoracic echo, an ultrasound looking at the heart. And here you see the heart, the bottom. We give a good idea of what's going on with the overall heart function. So an echo is like looking at the overall structure and function of the heart. Again, going with the house analogy, it's like going into a house, checking the walls, checking the doors, checking the function of the heart, the structure, okay? Gives you a rough idea of what's going on. Then the other thing we consider doing is a stress test. So that's where we typically put patients on a treadmill. You can also do a chemical stress test for patients who can't exercise. So there's a stress portion, and then there's a way you interpret the stress. So you can either look at just the EKGs, or you can look at, we'll go into a little bit more detail, but or you can look at the blood flow in the heart. So this is a nuclear stress test. So here we're measuring the blood flow in the heart. We're looking at the top images are at stress, and the bottom images are at rest. So you see at the top, the donuts, there's a break there, there's a hole there. So that's decreased blood flow in that area of the heart, okay? So what the stress test is doing is basically looking at if there's any problems with the plumbing. You can have blockages in the plumbing. If you have a 60-year-old house, there's gonna be plaque buildup, gunk in the pipes. But it may not be causing any problems. As long as the toilets are flushing, the sink is draining, it's okay. So the stress test, we're stressing the heart, and we're seeing, are those plaque buildup in the heart, is that causing any problems, okay? The other way that we can look at blockages in the arteries is a coronary CT angiogram. So coronary calcium score we talked about initially, there's no contrast. We're just looking at plaque. Just tells you, like a pipe, you can have gunk around the pipe, right? But blood can still be flowing, or water can still be flowing through the pipe. This is a test with contrast. So we're actually seeing the pipe and the arteries in your heart. We're seeing if they're open or not. So this is the most accurate test. If this is normal, there is no blockages in the arteries, okay? And that's a very good sign. The chest pain, the shortness of breath, all those things that you're having are probably not heart-related if the CT scan is normal. There could be some minor blockages that this doesn't pick up, but there's no major life-threatening blockage. So the CT scan is a very good procedure, and I Again, we do that here at Torrance Memorial. So the other thing that's helpful with the CT scan is that even if it's normal, no blockage, we can still see plaque. So on the left side, you see all this non-calcified plaque there, okay, that black stuff. And then here on the middle image, you see this calcified plaque here, and then you see a lot more calcified plaque here as well. So that tells me even though your arteries may be open and there's no blockage, you still may be at risk for heart disease in the future. So with the calcium score and with the CT scan, we can tell you, okay, based on other people, your age, your gender, what percentile plaque do you have? And I think that's really valuable. So the way I approach chest pain is, these symptoms, if someone is low risk, meaning their symptoms aren't typical, they're young, they don't have risk factors, I still, as Dr. Rezaeian said, we can still miss heart disease, so I start with a treadmill stress test. Put them on a treadmill, and you can do an echo with that as well. And I look to see if there's any EKG changes, if they have any chest pain while they exert themselves, look at their blood pressure, okay? Someone's intermediate risk, meaning diabetes, high blood pressure, they've got some typical symptoms, then I'll go with a CT scan because I don't want to miss the heart disease, okay? If someone's over the age of 70, CT scan tends to not be as accurate because there's a lot of calcium, and sometimes we can't see the arteries as well. If they have kidney failure or kidney problems, I don't want to give them dye or contrast with the CT scan, so I don't do that. Or they already have small stents in, the CT scan is not good. If someone is very high risk, meaning they're coming with a heart attack or they're coming in with very, very typical symptoms, very worrisome symptoms, then I send them straight to the cath lab to do an invasive angiogram at that time. So other symptoms that can sometimes be mistaken for blockages in the arteries or heart attacks is palpitations. So that's where you have rapid heartbeats, fluttering in the chest, dizziness, passing out. So those are all symptoms that we see every day in cardiology. So those get me worried about the electrical system of the heart. Okay, so that's when I go and do other tests, like looking at doing monitors on the heart. We can have on the top left, we can do a 24, 48-hour Holter monitor. We can do longer monitors here on the right side where you wear it for 2 weeks. We can even implant recorders underneath the skin of the heart, skin of the chest, where we look at for heart rhythms for 3 years. And then on the bottom right, Apple's now taking over, putting us out of business, and you can actually just use your Apple Watch to check your heart rhythm. So some patients have done that, and it's a new thing that we're just, we're testing out, but so far it's been helpful. So the one thing, when patients come in with palpitations, the one thing we worry about is if they have atrial fibrillation. Okay, so that's an arrhythmia of the heart where the top part of the heart is kind of beating irregularly, okay, and when that happens, blood can clot there, and that can go to the brain and cause a stroke. Okay, and women in particular are higher risk of having a stroke with atrial fibrillation. So it's very important that we check for that if you're having symptoms of palpitation. And if you do have atrial fibrillation, then we would start you potentially on a blood thinner, okay? We would, kind of monitor you for arrhythmias. And then if patients who are not able to tolerate blood thinners, now we have a new procedure where we can actually put a device in the heart that prevents blood clots from forming. That's only if patients can't tolerate blood thinners, but that's another option. But most of the time, the majority of patients I see who come in with palpitations, usually it's stress, anxiety, caffeine, all of those sorts of things. But we always do these tests just to make sure it's not atrial fibrillation. Just wanted to keep it brief, but wanted to thank you for your attention, leave you with one final kind of quote. Here at Torrance, we're superior doctors. We try to prevent the disease. Mediocre doctors treat the disease before it's evident, and inferior doctors treat the full-blown disease. Thank you for your attention.
All right, so the first one, and this I'll direct to both physicians, what is your opinion regarding the relationship between cardiovascular disease and insulin resistance or metabolic syndrome?
Okay, so that's very important question. So one of the things that they are teaching us in the medical school, if somebody has a diabetes type 2, I mean, they're telling mostly both of the diabetes, but then diabetes type 2, which is the insulin resistance, is equal to have the cardiovascular disease. It's equal to have a coronary artery disease. So how it is important and dangerous. So any patient with diabetes type 2, if you are going to see your doctor, two things they will tell you. On top of all the medication for diabetes, whatever you are taking, metformin or all those medication for diabetes, they will advise you two other things. One, start taking aspirin. It's very important. And no matter if you had a coronary artery disease before or not, as I mentioned, diabetes by itself is equal to cardiovascular disease. So they want you to start on aspirin, 81 milligram baby aspirin, and also they will ask you to start on a statin. So many patients saying, okay, doctor, my cholesterol is good. It does not matter. You need to start on the statin because you already have equivalent to coronary artery disease. So like the same thing we are telling the patient with the patient that already had a heart attack or coronary artery disease, you need to start a statin. Same story for the patient with diabetes type 2. I hope that I answered your question.
All right. Is it true that giving blood reduces heart attack risk by 50%?
I'm not sure if I understand your question. Are you talking about donating blood?
That was the impression that I got.
Okay, yeah. I did not see or read any study regarding that. I don't know if Dr. Banka heard any study supporting
No, but
that.
I'm sure it gets you good brownie points. So.
All right, so global coronary heart disease risks. Are you at higher risk if you are taking medications to lower your scores versus someone who has a low score without medications?
I don't know if it's the question about the calcium score, probably, right? If it's the question about the calcium score, I think that Dr. Banka is the better person to answer, but I think does have the lower score by itself, it means you have in the healthier profile as far as a cardiovascular disease. But Dr. Banka, do you have any idea about this question? I don't know if I understand the question right.
Well, they specifically said CHD, which is coronary heart disease. And I think I understand the question. Are you at lower risk if you don't need meds versus the person who has tried to lower their risk by being on meds? Do you end up being in the same group?
I think it's a difficult question to answer without knowing the specifics. I mean, again, I like to look at everything, in terms of the lipid panel, diabetes, calcium score, blood pressure, family history, all of those things. And we have calculators and we have that give us what your overall risk is. So just based on one blood test, cholesterol, or one blood test in terms of diabetes, or one blood pressure reading, it's very difficult to give a global assessment. I think you really have to put it all together and look at someone's risk. I guess if someone has so that would be the way I'd answer it. I think it's very difficult to answer just based on one test alone.
Okay. Should an 80-year-old woman start on statins, and if so, under what conditions?
That's a very good question. It depends again on the patient. So if you have if I have a frail 80-year-old who has a low life expectancy, I probably will not start it at that point. But there's a lot of 80-year-olds who are driving, active, healthy, who have 10, 15 years ahead of them. And those patients, again, I would sit down and have a discussion, look at what their overall risk is. And if the risk is high, which generally at the age of 80, the risk does, for most people, there is an increased risk of heart disease. So I probably would start a statin if it's a healthy, active 80-year-old.
And I kind of address that in the same way when I deal with patients. You know, if you're 80 and you're doing well and you're looking at you might make it to 90 or 95, you want those last 15 years to be some of your best years. And if you invest in making sure you're as healthy as you can be, that it's going to end up paying off in the end. Now we're going to talk about a couple of specific issues directed at the woman who's been treated for breast cancer. Is being on a aromatase inhibitor increase the risk of speeding up cardiovascular disease in women? Or having right breast radiation, can that have a impact on CAD in women? I guess radiation in general.
Yeah. So radiation is a risk factor for heart disease. A lot of it depends on when the radiation was. 20, 30 years ago when they were doing radiation, there wasn't as much of a concern about cardiotoxicity. Now the radiation is much more focused and is much less to the heart. But I had my own personal mother had radiation to her chest for breast cancer, and I made her get a calcium score, and her calcium score was the 99th percentile. So I think everyone is different, so it really has to be personalized. But yes, radiation is a risk factor for heart disease. And the aromatase inhibitor, I don't think we have enough information on at this point. As Dr. Rezaeian said, we don't fully understand how the hormones, the estrogen, progesterone, affects women. We know that estrogen probably serves some protective role in women because women have their average age of onset of heart disease is 10 years later and tends to happen 10 years after the onset of menopause. But we do have conflicting evidence on taking oral replacement therapy, which we do not think is protective anymore, and it's probably okay in the short term, but long term we think it probably does have some negative effect on women. So to answer the question on the aromatase inhibitor, we just don't know.
Okay. We've read that statins are not good. I'm taking Welchol. Is this better or worse?
Statin still is, as I mentioned, saving lives. They are just mentioning in all those brochures because technically, legally, they have to mention all single side effect, even happen in very, very rare or just small percentage of the people. They are just, putting lots of stuff in the media, but still statin, that's the one, shows saving lives.
Yeah, Welchol specifically, there isn't a lot of good data on having much benefit. Statins are not the only, but they're the main medication that has benefits. Now the side effects for statins, I tell my patients 10 to 15% of patients have muscle aches with statin medications. It's a known side effect. It goes away after you stop the statin medication within 24 to 48 hours mostly. If someone's really concerned or they're sensitive to medications, I'll start them off as low as taking the medication once a week and then slowly increasing it to 2 times, 3 times, 4 times, 5 times, eventually daily, and again starting them on the lowest dose. So, the statins is it's not going to make an immediate impact within days or months. It's something that it takes years to have that impact. So for patients who are concerned about side effects, I go very slowly with them.
It's my personal experience. I had a patient came to me and said, doctor, I'm not taking a statin anymore because I start having the muscle pain, joint pain. I was talking with my neighbor. She has the similar symptoms, knee pains, and then I'm not taking it. Whatever you are telling me, it doesn't matter. I'm not taking it. And I asked more questions. She had the knee pain and joint pain and all of those symptoms 10 years before starting statin. So it's just, please put just, those all different side effects together the time that you start and see if it's really related.
If you have plaque buildup, can this be reversed with diet and exercise? And I'm going to add, can it be reversed then if you get on a statin and do the other treatments?
So I think the goal is to really stabilize the plaque. There may be some minimal decrease in the plaque burden, but the goal is to stabilize it. So I tell my patients, I'm not expecting the plaque burden to decrease. The calcium score will not decrease. The goal is to really stabilize it. And the calcium, we think, is not a bad thing. The calcium is protecting the soft plaque from erupting. The analogy I use is, if you're driving down the road and there's some potholes, okay, that's bad. The city comes in and put tar over the plaque, or over those pots. That's protecting the road and protecting your car. The tar is like the calcium. The calcium is protecting your heart from the plaque exploding and causing a heart attack. But it's a bad sign. It's a sign that there's bad things going on in the heart.
So again, just to expound on that a little bit more, the calcium itself is not the problem. It's the presence of the calcium indicates what the disease is. All right, this is a question specifically about somebody who has an HDL of 110. Should this person be on statins? Total calcium was 220.
So actually, they did a study in Japan, I believe 2-3 years ago, and they showed that the high good cholesterol, or HDL, also could be a sign of risk. But the other study did not really support that, so still we need to do more study. But technically, the HDL is the good cholesterol, and based on the guidelines from American College of Cardiology, National Lipidology Society, and also the American Heart Association, the target for the cholesterol and just statin therapy is the bad cholesterol, or LDL. So saying that if the patient had the high total cholesterol high because the good cholesterol is high, but the LDL is low, not necessarily we are that much worried. I don't know if you want to correct me, Dr. Banka.
Yeah, I think there's a lot of, the high HDL is interesting, and we need a lot more research on that area. But there are some theories saying if the HDL is that high, 110, that might be a sign of some dysfunction of the HDL. So again, I would go back to what the overall risk for the patient is, but I would definitely be suspicious that there may be higher risk for heart disease with that high of an HDL.
Okay, I've got a lot of questions on the coronary calcium, so we're going to dig into those. If you have a high coronary calcium score, can it be lowered, or will it always stay the same?
So the goal is to stabilize it. Because we talked about it can't be lowered, we want to prevent it from progressing.
All right. Do you need a doctor's order? And what if you have a doctor that won't give you that order?
So currently here at Torrance Memorial, I think you do need a doctor's order. I think there's been a lot of questions about that tonight, so I'm actually going to talk to the department about changing that so that you don't need a doctor's order. So at this moment, you do need a doctor's order. If you could, at Harbor UCLA, you can actually walk in and get it without a doctor's order.
All right. This patient has palpitations and is on Coreg. The blood pressure is controlled on hydrochlorothiazide and benazepril. This person is on Lipitor, has a very extensive family history of a gene defect that doesn't allow the proper breakdown of cholesterol, a lot of heart disease and kidney disease in the family. Should I have a coronary calcium score? The primary doctor has been unwilling to do the test.
So I think in that case, it sounds like patient's already on a statin medication, they're already on their blood pressure is controlled. Sounds like they're aware of their family history, and presumably they're doing their diet and exercise. So that would be a patient who I think the calcium score would not be beneficial for, because they're already doing all of the things that we would do with a high calcium score. I would assume the calcium score is high, and I would treat them aggressively.
All right, the latest guidelines, November 2018, from the ACC recommend coronary calcium for supporting info regarding whether statins should be prescribed. Will that change eventually affect insurance coverage?
That is my hope. Actually, your last slide in the packet for me it shows that guideline. Didn't want to bore you with that, but that is our hope that in the future that will change insurance companies and make them start covering it.
If you've had the nuclear test, do you need a calcium test?
So the nuclear stress test, so I would say yes, I would, again, assuming you're not on a statin, you're not doing all the other things, the nuclear stress test is just looking for gross problems with blood flow. You can still have normal blood flow in the heart, but still have a lot of calcium and plaque, and then you would want to take a statin and do all those other things. So yes, I frequently do, and actually in some places they can actually they actually do a CT scan with the nuclear stress so you can see calcium and plaque buildup, and that's something that I'm hoping in the future we can have here as well.
A question that I might have more from a physician standpoint, is there any benefit to some of these other tests being a little safer than catheterizations? Will we move more away from catheterizations?
Yeah, the number of cardiac caths has dramatically declined in the last 10, 20 years, partially because a lot of unnecessary caths were done 20 years ago when they didn't fully understand how heart disease works. But now we have all these more accurate, non-invasive ways of looking at heart disease. So interventional cardiologists are not doing as many caths as they once were.
Do we know why women are more at risk for blood clots with AFib?
It was a discussion last year. If the question about why the women has more atrial fibrillation, I don't know. The actual reason is still not very clear to me. I don't know if Dr. Banka read something new about that, but
So I think the question was, why are they higher risk for blood clots if you have AFib? And I don't think that may be related to the hormones, but
sorry, I didn't understand the question first. So that's really related to the I mentioned that the estrogen by itself can increase the possibility of the clotting. For example, if the patient has the family history of the blood clot, before start the patient on the oral contraceptive, which include the estrogen, or previously they used to put the patient on some oral contraceptive, mostly only estrogen. They were just asking, if you have a family history, we are not putting you because increase the risk of the blood clot. So the fact that the estrogen increased that blood clot is the fact that we know, and could be related to that. That those patients had, the patient with atrial fibrillation, the women patient with atrial fibrillation had more clots, blood clots.
So I have two questions here specifically about diets. Just kind of talk in general about what the Mediterranean diet is and how is it different than other diets. Then another one is, what is your opinion on the plant-based diet?
So the Mediterranean diet is mostly include the vegetables, legumes, and then after that we can go into the fish. Make sure that the fish you are taking is not mercury rich, so just that's put it in your mind. And then poultry maybe once or twice a week, and make sure if you are taking poultry, taking the white part, so the breast, not the dark part, because the dark part has more cholesterol, and also remove all the skins because those also have the more cholesterol. And a small little portion is the red meat. So that's one thing about the Mediterranean diet. So many studies shows that not only decreasing the cardiovascular disease in the men and women both, also decrease the risk of cancer. So it's the number one recommendation, diet recommended by the American Heart Association and American College of Cardiology.
yeah, I recommend basically everything in moderation. Not everything in moderation, but moderation is important. So the question on the plant-based diet, I think there is definitely some advantages to that in the sense that you're avoiding red meat, you're avoiding a lot of fatty foods with cholesterol. But there's also a lot of downsides with the plant-based diet in that you eat a lot of simple carbohydrates, and so that leads to an increase in diabetes. For example, my family is from India originally, and there's a higher incidence of heart disease in the South Asian population. Part of it's thought to be genetic, part of it's also thought to be diet, because it's a very plant-based heavy diet, but there's a lot of carbohydrates with it, so there's a lot of centripetal obesity, there's a lot of diabetes. So again, everything in moderation.
And some of the diets, which they are saying just, especially the vegetarians, not the vegans, but the vegetarians, some of them using a lots of oil during the cooking, so that also can increase the chance of the cholesterol.
All right. Can you explain on how to determine if a woman is having pressure or tightness in the chest with persistent belching, if this is just indigestion and not a sign of an impending heart attack?
So if you remember my slide about the women may have, mostly they have non-obstructive coronary artery disease and more possibility of the microvascular disease, so the disease of the smaller arteries. And then do you remember I mentioned those people, especially people that have a microvascular disease, they have very non-specific, and then the symptoms were basically just vague chest pressure, not the crushing chest pain, and mostly indigestion. So because the most of the women has the microvascular disease, number one, they do not have a clot that suddenly go and stop the coronary artery disease, and the symptoms not as traumatic, is not stopping. When we will have the coronary blockage, especially those people that they have a blood clot, especially in the sudden cardiac attack, the heart muscle not getting enough oxygen, so start dying suddenly. So that sudden event can start sudden symptoms. But as you could see in the both type of the problem the women can have the problem in the smaller vessels, they do not have that much of the big area of the heart muscle to die when there is some kind of the circulation problem, number one. Also, then the bigger coronary artery disease, as you could see, is just tapering off the lumen or inside the vessel very smoothly. So we do not have a clot suddenly block the circulation and oxygen to the blood. So that's what we know that could explain that difference of the symptoms.
Yeah, it's very difficult to diagnose, a heart attack or heart symptoms, but I think sometimes a little bit of common sense, if you're having indigestion after eating, that probably isn't your heart. If you take a Tums, it gets better. If it gets better with belching, it's probably not the heart. If it's, chest pain if you push on the chest, that's probably a muscle. So, there's lots of different things that I would talk to your doctor about. Go to an urgent care. If you're having those symptoms that are persisting, or if it's severe, go to an emergency room. But I think if it's self-limiting, it's brief, it resolves with some of the things we talked about, less likely to be heart disease. But it's hard to be definitive without getting EKG and a blood test. So if you come into the ER here, they do an EKG to make sure you're not having a heart attack, and they do a blood test to look to see if there's a muscle enzyme for a heart attack, and those things can be done right away. And if the symptoms go away, we usually send the patients home. If they're risk factors, we keep them overnight and do a stress test in the hospital.
And I think he has a good point. Sometimes you just have to be persistent and have enough tests done to make sure that everybody's happy with it. Once the tests are done, then you can sit back and don't focus on that. But sometimes it does pay to be persistent.
And just, same thing that Dr. Miller mentioned, if you are getting enough treatment for the acid reflux and still you have symptoms, please make sure that you are getting all those tests to rule out the coronary artery disease. Because unfortunately, the coronary artery disease also could be induced by stress as well. They used to say only the activity or exercise induced chest pain is the coronary artery disease, but recently they put also the stress as induced chest pain as a coronary artery disease.
Okay. This is kind of a basic question, but I had a couple like this. What is the actual cause of the plaque? Where kind of maybe talk about just how does plaque come to be?
So, it's very, very complicated. Atherosclerosis is being heavily researched, but essentially there's lipids and cholesterol that accumulate in the arteries. There's damage to the vessel from stress. There's damage to the vessel from high blood pressure, and then there's buildup of disease from diabetes. So all of those things kind of weaken the vessel wall. If you remember the one slide I had where that showed the progression of disease, so first there's inflammation, there's plaque buildup, there's stress on the arteries, there's damage to the vessel wall of the arteries, then there's, the plaque builds up. Sometimes the plaque ruptures, that causes a heart attack. Sometimes calcium comes, stabilizes that plaque, but that calcium can cause blockages that slowly develop. So it's very complicated, but those are the main factors involved.
As Dr. Banka mentioned, and you could see in his slides, I remember my patient asking, they were thinking that, okay, the coronary artery vessels is like a pipe, and getting clogged by the fat plugs, like same thing that happened in the plumbing or on sinks. So when you are putting the fat or just grease going to the pipe, it's just stick on the surface, which is not as simple as this. And they were thinking, okay, if you are just doing, I heard some funny things. I don't know if it was the joke or something. They said if you are eating the fatty food, immediately after that, drink the hot water because it's just clean off. The same thing happened. I mean, it's not like this. It's not cleaning the coronary artery disease by drinking the hot tea or hot water.
All right. If there's throbbing on the side of the neck, does that indicate a heart problem?
It could be, but as Dr. Banka mentioned, it's really difficult to just by one sign or symptoms just diagnose the patient with coronary artery disease. So for that, answer that question, please go to see your doctor. They will check so many other things, including that pain you have, make sure it's related to the heart, it's not explained by any other sign or symptoms or any other risk factor.
This is a question that I get a lot in the clinic. Is it concerning when a patient states that they can hear their heartbeat in their ears in the middle of the night or waking up in the morning?
Possibly, but that's something that we can answer very easily with a monitor. So, I see a lot of patients with those symptoms every day, and anecdotally, probably 80% of those patients have nothing. It's just stress, anxiety. There's no arrhythmia of the heart. But there's a fraction of those patients who we do find arrhythmias on. We do find atrial fibrillation. We do find other problems. So the answer is possible, and I would do some sort of monitoring of the heart to find out.
Please mention PVCs. Are these something to worry about?
Yeah, so as I talked about, the palpitations can be benign, and I didn't get time to really go into it, but PVCs are generally a benign sort of palpitation. I explain them to patients as they're hiccups of the heart. It's an early beat that comes in. So if there's a low percentage of PVCs, we're talking about less than 5 to 10% of PVCs. It's generally nothing to worry about. Over 20% of beats, so 1 in every 5 beats, if that's a PVC, that's an early beat, that can cause heart dysfunction over years. So if patients sometimes feel those PVCs, we'll put them on medications like beta blockers to suppress those PVCs, but sometimes they have side effects of those medications as well. So if we see patients all the time who've incidentally been found to have PVCs, and if there's a low percentage, we don't do anything about it generally.
All right, can you explain the meaning of aortic dissection, and is it life-threatening?
Yeah, aortic dissection is a life-threatening condition, and that's when there's a tear in the aorta. So the heart pumps out blood into the main artery called the aorta, and that goes to the rest of the body. When there's a dissection, meaning there's a tear in that artery. So that's a life-threatening condition, and that's typically, again, everyone presents differently, but a typical classic presentation, someone has ripping chest pain that's radiating to their back. So that's one of those situations where you go to the emergency room right away, and you're generally taken to the operating room that night.
Since marijuana is now legal and the use is probably going to increase, is there a connection to heart or stroke problems with daily use of pot, especially in younger people?
Still is too early to decide because just recently legalized, but there is a lots of side effects, and some of them also is related to the cardiovascular problem in general, not necessarily heart attack. And we can see, because not only always is just the weed or pot or smoking, there is some other stuff they put just next to it, like sometimes the cocaine or those things. So all of those things are not good for the heart. One of the things I want to take the chance and speak about that is the e-cigarettes and vaping. I'm telling all of my patients, especially younger generation, is not safe. Don't think you're not smoking, you are safe. No, there's so many studies shows. Actually, I was reading an article a few weeks ago. Is increasing the number of the heart problem. I don't know. It was I think it was not a mortality, but it was the heart symptoms and heart disease in the people that they have the e-cigarettes and they have vaping. So the answer is no. It's not safe. Please do not go into that stuff.
And the last question, the person was interested if Torrance Hospital is expecting to cooperate with Cedars-Sinai with any kind of a heart center, maybe similar to what they're doing with stroke.
Yeah, so we are actively working with Cedars. We have their heart failure group comes here to see patients once a month. So those are patients with end-stage heart failure who are looking for advanced mechanical support. We work very closely with the Cedars cardiac surgeons, so they're operating here every day. They're seeing our patients here in clinic. So those are the kind of the main areas that we're working on right now, and then in the future.
Yeah, hopefully we will have even more collaboration with the cardiovascular group and including Women Cardiovascular Center. And before just finishing that session, I want to mention something before I forget. So we are interested to start the preventive cardiology support group or the cardiovascular disease support group, similar to what we have in the diabetes and all those different diseases. So it just came to my mind. I don't know if your audience thinking that's something that could be helpful. I believe that's very important. is number one killer of the men and women. If you are interested, please just mention it and then put your name and contacting information. Then if we see that we have enough interest from the community, then I can just go and proceed with starting the process and start having the meeting, just, could be monthly or weekly based on your interest about the support group of cardiovascular disease, men and women.
So I'd like to have us all thank our physicians. They really opened up a lot of thought. And then I'm going to have you guys give yourselves a round of applause because these are some of the best questions, and that made the question and answer very interesting.